Well, I was sitting here listening to Allison's recommendations, and I was saying, if I come from a safety net hospital, and some of the same challenges that were articulated for safety net for human services organizations are very much live and well, unfortunately, in safety net organizations. So you talked about margin or lack thereof. In spite of those challenges around risk, we are still being expected to do value-based contracting. In spite of the lack of a margin to make investments, we must provide and be involved in collaborations with human resource organizations because of the communities that we serve. So part of what I was thinking about as the recommendations were laid out there was the need for there to be a recognition that there are levels of or ranges in terms of healthcare organizations and particularly hospitals' capacity to, in effect, put in place the types of essential and critical and absolutely needed collaborative arrangements and contractual arrangements. So I think some of us are in the same boat. But that's not a bad thing, because I think being in the same boat, there's also a level of sensitivity and understanding that you start with, and if there is a will, then you can move forward with trust, and frankly, jumping into it together is really important. But I just wanted to say that all hospitals are not the same. All healthcare organizations are not the same. And so the issue of whether there is in fact an infrastructure to do this kind of collaboration should not be assumed that if you have a hospital, that they also are on the side of, the balance of power. Some hospitals, small community-based hospitals, and particularly those that we don't even have a margin. You talked about somebody having 30-some days or in cash. I have 2 weeks of cash on hand. So, I just want to do some level setting there as well.
Thank you. Denard? Well, thank you for having me this morning. Actually, my general reactions to the report were positive. Like, I had an opportunity to read the report before this morning's summary, and I found it actually very validating in terms of the work that we're doing. I've only been in this position since December of 2017, so not very long, but I've had the opportunity to attend many convenings with the CBO community, Human Service CBO community, with the Human Service CBO community, and many of the issues that you were addressing, we've heard, and we are thinking of ways to actually address them on the state level, and to also build on some of the successes of the investments that the state has made in terms of the district program. So, my reaction was overall positive.
Yeah. Well, Denard, if you could humor us for a minute, because I suspect that many of you didn't know the state had a Bureau of the Social Determinants of Health. And so if you can give us a 2-minute overview of what the Bureau's charge is, that would be helpful.
Oh, awesome. I can do it. Well, just show of hands, how many people actually knew that there was a Bureau of Social Determinants of Health? All right, so maybe could I have more than 2 minutes? Yeah. I'm just kidding. So I'll give you just a high level of what we're doing, and I realize, and I'm coming to realize that the responsibilities of the Bureau expand almost daily. Like we were initially established to implement the VBP roadmap requirements. So within the approved VBP roadmap, there are 2 specific requirements that we're responsible to implement. One was that for every level 2 and 3 VBP arrangement, there must include a social determinant of health intervention. The other requirement was that for every level 2 and 3 VBP arrangement, that they must contract with at least one Tier 1 CBO. And so when we were originally established, we were established to make sure that the managed care organizations and the VBP contractors are actually adhering to these 2 requirements, because we're moving to a place where it's no longer an option, but it's now a requirement, and there will be penalties assessed if these requirements are not met. And so that was the reason we were established. once we were established, we begin to realize that there is a cultural divide that exists between the managed care organizations, the VBP contractors, and the CBOs. Unfortunately, you all don't speak the same language. You're working with the same people, not speaking the same language, and then there was a lack of understanding in terms of what the real goals of VBP were. So we were assigned to do stakeholder engagement. And so in the course of doing stakeholder engagements, we plan on hosting regional learning collaboratives just to enhance the functional understanding across sectors. So we plan on having collaboratives where we have networking opportunities for the managed care organizations, the human service CBOs, and the VBP contractors to sit in the same room and kind of discuss the issues for your region and how to best address them. As was mentioned in the summary of the report, we recognize that there needs to be an improved way to collect social determinant of health information. There's not a standardized way to do it. There are no quality measures out there to track it. And so one of the things that we're doing is want to enhance data collection and data collection capacity for this social determinant of health, as well as standardize the social determinant of health quality measures and incorporate this into the QAR if possible. Another thing that we're possibly considering is to do risk adjustment. Massachusetts is actually doing risk adjustment for social determinants work, and we're looking at that as an option for New York State. Two more things and then I'll be done. One is addressing the trailing prevention agenda items. So we'll implement a dedicated value-based arrangement pilot to focus specifically on achieving trailing prevention agenda items led through a CBO with a CBO focus leading the way in this effort. And then finally, prior to being rebranded the Bureau of Social Determinants of Health, we were actually the Bureau of Supportive Housing. So we are not completely new to social determinants work. We just have an expanded focus at this point in time. And we recognize that in supportive housing, the way that you actually get the biggest impact of supportive housing is to actually target appropriately and to ensure that you're actually placing the right person into a unit, the person who most needs the unit, and the person who's ready to actually move into the unit. So another thing that we're going to be looking to do is increase coordination between the MCOs, VBP contractors, and provider networks to identify and place participants into the MRT supportive housing program, which is still in existence and robust. So that's my quick. I hope I didn't go too far.
Oh, no. That's great. I think because there's so much alignment with what you're planning to do and the recommendations of this report. Allison, I think you can take credit for his actions.
Thanks, Allison.
Thank you.
Margaret, any first general reactions to the report?
Well, I had the privilege of being on the commission, so it was more than a year that we've been meeting. And one of the, I think, great things that I learned, first of all, it was an amazing learning experience, so thank you to the people who are on the commission, and thank you for convening us. But I do think we went through sort of what's different now than in the 90s, and why are we just rehashing the managed care conversations. And from my partnership with Children Provides Behavioral Health Services in schools, only in schools. We're funded mostly by the DOE, a little bit by the DOH-MH, and then some private funding. But we believe that people are more likely to access care and services if it's at a place that they go anyways. And so that, for us, it works that it's a school. When I started going to these meetings, I started realizing how much more information we had that was valuable to these conversations, and what makes it different now. And I think that's what's really exciting. First, we've all realized that we need to be in a community. So the four walls of any kind of clinic are a barrier to access in many cases, and that has a lot to do with stress, with years of institutional racism, with the way that people feel about all sorts of systems. So we've realized that. We've also starting to really think a lot about social determinants of health. And if you hadn't seen it, the article in the New York Times Magazine this Sunday, which seemed a little bit overdue, on, why is it that Black women are having preterm labor and low birth weight all these years? And literally somebody's like, maybe it has to do with stress. So we think a lot about trauma. And so I could tell you for the 13,000 kids in our program how many ACEs they've had. And what do I do with that? I then think about attendance, I think about test scores, but I don't have any way to give that to a healthcare provider. My kids are the ones who go to the emergency room for asthma. And I can tell you how many times they go, but I don't know now what to do with that information. I can tell you that they then go home to a mold-filled home or a shelter, but again, there's really nowhere for me to give that information. So, and then I think the last thing that I'll say that makes this an exciting time is that the neuroscience has really caught up to the work we've all been doing in the human services sector. We have a long-term social worker who's worked with us for over 30 years. And she has this little speech that she gives. She's like, well, at least the neuroscience is confirming what I've been doing all these years. So luckily, I'd be out of a job a long time ago. And so I do think this is an exciting time. And if I were an economist looking down from another planet at our healthcare system, or even like from Sweden, if I were looking at our, I'd be scratching my head thinking this is not the way to set things up. So thank you again.
Great. So let's circle back to the first recommendation, which actually took up a large part of the Commission's deliberation, and that's related to the technology divide between the healthcare system and the human services sector. So let's start with Lorraine and Margaret. Have you experienced hurdles related to this technology divide, and how has technology worked or created challenges in connecting health and human services?
So, I would start with that yes, the answer is absolutely yes. But I would also say that, we can maybe learn from something that was done. I recall many years ago, the City Department of Health and Mental Hygiene invested in eClinicWorks, right? They made that investment. So, Allison's recommendation about government at least making an investment is important. But they made that investment into primary care practices in order to link those primary care practices to hospitals. So at least there's a recommendation that is very consistent with and I believe that was a success. I don't believe it was a flaming success, but it was a start, and it enabled practices to be able to provide greater continuity, with hospitals and emergency rooms, et cetera. But it recognized that if you wanted to engage a sector into the system, the investment was necessary. So that first recommendation was really resonating. I would also say that the RIOs, I think, is still an experiment. I'm not feeling anything from the RIOs. I mean, they haven't improved my life, and I don't know if there's anybody here from a RIO, and I know the people who run it, and I love them as friends, but the RIOs have not improved. From a hospital's perspective, the promise has not been met. So I also say we should balance the expectation about technology, right? We shouldn't see it as it's going to be a magic, pill, because it's not. But I do think that if there's been investments already in things like RIOs, then broaden them in terms of their role. Don't start all over again. And hopefully in that context, their original mission can be achieved, but to make it a more global mission in terms of the various and essential collaborations that are necessary.
Great. Margaret, comments on the technology divide?
Yeah, I think it's going to all be about technology. I was at a panel the other day, which I think a lot of us were, on children's behavioral health being sort of the next frontier, scaling that. And somebody said, we've been doing pilots for 40 years. And why can we not scale that? And I think it's because we don't have ways of sharing data. And then my husband, I've been cursing him all morning because he comes home last night and he's like, oh, you guys have it all wrong. It's about blockchain. Why do you think Amazon's in the business? Because they're using data to change consumer behavior. And frankly, that's the business we're in too. And yet we don't really have the way of tracking it. So we have, and I'm grateful. Chris Caruso is here, who's the head of the Office of Community Schools, which is, I think, I'm delighted to see you here because what's so fascinating is community schools are really in the business of providing well-being, right? We're tracking all the social determinants of health. And then we go out, so we're doing that. And now we go out to United Healthcare, who's also here. We have a member on our board who works at United Healthcare. And they're like, you know what, could you just plug into us? Can you share that with us? Because otherwise we're going out and we're hiring our own community healthcare workers. So there's a fifth person coming to our families' homes, and United Healthcare is paying them full FTE plus fringe, probably way more than I'm paying my staff, and we can't hook into their system. We can't actually, we can have those conversations in a boardroom, but I don't have any way of sharing our data with them. And even with other CBOs, so we've got great little Excel spreadsheets where we're subcontracting to a bunch of CBOs, but when we try to figure out how can we actually have clinics in our schools and share data where there's all sorts of technology roadblocks. And when you call for a uniform system, I think there's like, this is starting SAP from the beginning. But really, I think it's a series of APIs. And, and Apple's going to beat us all to this. Amazon's going to beat us all to this. It's just ways that we can plug in and figure out. And I think the biggest problem is privacy. And with us, there's also a little bit of territoriality of, forgive me, but like the DOE and the DOHMH. And that's all about technology. And I think the big thing is really figuring out how to protect privacy so that we're all comfortable.
So Denard, so Lorraine actually brought up a good parallel from the healthcare community, the investment in eClinical Works from the New York City Health Department in primary care, the investment into the RIOs, and then the report brings up this recommendation that Margaret referenced again, this potential for a state-supported public good system. Is this reasonable? As a reasonable approach to address this technology divide, or are there other ways to do it, or is it a matter of creating APIs for everybody's different systems?
I'm going to address this. I'm going to answer this in a couple of different ways, because there's so many different components of this issue that were kind of built into everyone's statements. And so first, I would say thank you, Lorraine, for mentioning that what we really should be thinking about is like broadening the role of the RIO. So it's important to understand that the state has made significant investments into the infrastructure at the RIOs and with the PPSs, and I think that the success of what we're trying to accomplish here is having like a regional approach or a local approach. And so I think that the solution to this, or at least the first step to this, is actually utilizing this infrastructure that has been invested in and that's in place, and then looking to the future to see if there is a possibility to expand on that. I had the opportunity early in my career, working for the state, to be the budget analyst that was responsible for the Connections program in New York. It's a huge program that's used by the Office of Children and Family Services. Developing statewide systems is very cumbersome and it's very expensive. And it's not to say that the ask is unreasonable, but I think that in order to be agile enough to address the needs that currently exist, I think we should try to work within the structures that are in place to get to maximize the efficiency that they're providing.
So what I'm hearing, and correct me if I'm wrong, is maybe if we think about public good as a generic term, that you're acknowledging that there is a role for the state to intervene, but it isn't necessarily, let's say, a single system for everybody, but it may be a different type of approach. But it seems to sound reasonable that the state might take a role in trying to bridge the technology divide.
Absolutely.
Excellent. Well, I think the next topic I'm going to tee up has a lot to do with the state as well, and that's regulation. And I know that's a point of discussion that is heated among both the healthcare side and the human services side. And the report, of course, points out the need to overhaul regulations and suggests that the rules that are currently in place are really focused on process-related, volume-related, rather than value, and particularly for CBOs, but I know that it's true for healthcare as well. Margaret, can you give an example of how the current regulations, how this hinders the transition to value in your work?
I'm trying to choose. I think for us, one of the most obvious is, so we're in behavioral health work. We're actually not in Article 31. And the reason we're not in Article 31 is because there's no way that we have the administrative capacity to become an Article 31. I have board members who are like, why wouldn't you do it? We don't, the volume and scale that we need to work up to I think that would be a clear path to insolvency. We have the DOH-MH saying to us, if you could just become an Article 31, you do some of the best work out there, that would be easier for us. And that's just a roadblock. So now we're partnering with Article 31 so we access Medicaid funding, but the regulations to put clinics in schools are you have to have a room a certain size with certain windows, and schools don't always have that. You can't bill for a 30-minute session, and sometimes you can only do a 30-minute session. So what we're finding is if we want to meet people where they are and we want to meet communities where they are, the regulations just don't work. And the billing mechanisms are so difficult.
Yeah. Well, I found it interesting that the state's current regulatory modernization initiative doesn't actually touch on CBO operations right now. So, Denard, what is the state's perspective on making changes to the rules and regulations relating to CBOs as they try to encourage participation in this new world?
Well, I think that there's a consciousness from the state's perspective that the system reform demands a regulatory modernization. The state has demonstrated the willingness to be flexible in accommodating these reforms with the regulation waivers offered in connection with the district program. As you mentioned, the Office of Primary Care and Health Service Management is currently engaging in regulatory modernization. I think that there's an awareness that if we're moving from volume to value, that there are going to need to be some changes. I think that what will help the state is that if we were able to maybe hear more about, okay, well, these are the barriers. These are the things that are stopping me from being innovative. These are things that we can change. It's similar to the process that was used for the RMI. There was work groups that came together and said, these are the areas that we need to look at. These are the things we need to change. And then the state was able to assess those asks and then, if it was possible, make the change. So I think that the start in this area, because you're right, there was no SDHCBO component of the RMI. The success would be to actually pull together a group of stakeholders and try to understand what those barriers are and how we can actually address them.
Lorraine, do you want to comment at all on this, or?
Well, I would just comment on the difficulty of trying to collaborate. I'll give a very current issue that I'm suffering. It was mentioned that I'm the CEO of One Brooklyn Health System, which is like a 2-week-old system. So congratulate me, I guess, but whatever that means. But one of the great things that has happened is that the state awarded us, we haven't gotten the money, but awarded us a significant amount of money for capital investment. And included in that capital investment is a $200 million of capital funding to create an ambulatory care network. My approach, even with the headwinds of initially the board, my approach was hospitals don't do ambulatory care all that great. And so we need to partner with those who do, FQHCs and even some community practices, et cetera. So, we put our toe in and actually included more than $30 million of funding that would go directly to some of the FQHCs that are in Central Brooklyn. So I had a big meeting with the state on Friday, and they were pushing this. They were supporting this collaboration. And then they say, well, the money's got to come through One Brooklyn, Lorraine, and DASNY's got some requirements as to how capital dollars can go to entities. And they started listing all the things that we had to consider. I'm like, my head was in about like, now what do I tell my FQHC partners? Because they've now loaded on additional requirements to those FQHCs that don't necessarily have the infrastructure to support the levels of reporting and as to the capital program. I'm looking at my friend Louise Cohen here. I'm sure she can appreciate some of this complexity. But my whole point is, at every turn of trying to do the right thing, there are, as you know, Denard, there are some huge headwinds in terms of regulatory requirements, accountability requirements, all of which are good and I believe are important in terms of having accountability, but they don't help us to move forward. My 2 cents.
And in case you missed it before, although Lorraine is CEO of One Brooklyn Health, she is retaining her role as CEO of Interfaith Medical System, so she just signed on for an additional 80-hour job on top of her 80-hour job. Denard, I think you covered part of this before in terms of what you're doing to trying to foster CBO healthcare partnerships. And I know Allison mentioned the survey to CBOs across the state and the creation of behavioral health care collaboratives. Can you talk about kind of what further things you're planning to foster the relationships between the healthcare and human services sectors?
Absolutely. I am not ashamed to do shameless plugs, and so I will say that the CBO survey is still live, and so for individuals who have not taken part in the survey, we would encourage you to, and if you are part of a network, we'd encourage you to encourage your network to complete the CBO survey. But on that point, we created this CBO survey, which is used to create a directory, because one of the things that we were hearing we hear from both sides. The CBOs are saying, well, I have no idea how to get in contact with the MCO. I don't know who to speak to or where to start this process. And then you speak to the MCOs, they're saying the same thing. I have no idea how to get in touch with the CBOs or I don't really fully understand like what it is that they do. And so with that being out there, we decided to actually, as I mentioned earlier, host regional learning collaboratives. And part of the collaboratives will be to speak to this notion of value proposition. Part of the collaborative will be just speaking the same language, getting on the same page. And then the hope is building on some of the successes of the district program, because I know that this was done by my colleague Peggy Chandler. She's here somewhere.
She's there.
She's here somewhere. This type of work was done where you actually get all the players in the room and you allow them to actually to speak and to see the value that they bring and the differences that exist. And so I think that on the horizon, I think that there's a lot of work that's being done through the district program. The PPSs are doing a lot of this work, and then what we're planning on doing is like bringing in the regional learning collaboratives and to allow for the networking to take place in that environment. Just creating kind of a safe space for that. Yeah, to happen.
Lorraine, so in addition to getting rid of the barriers that you identified before, what else would help you connect to these CBOs? And do you have an example of a successful partnership that you're currently engaged with? That's our friend from Italy.
I think there are a lot of the examples I can give just from Interfaith's perspective. So in terms of human services organizations, religious organizations, our ambulatory care center, Bishop Walker, has relationships with a myriad of the daycare centers in the community. We're also working with faith-based organizations around getting just literally, we send the physicians and medical residents to what comes to mind is a recent arrangement with a particular church that, as part of its health ministry, convenes groups of individuals, members of their church, but also members from the community, to learn and to engage with that clinical staff around certain areas in terms of health and wellness. And I think that's a beginning because we recognize that, as I think Margaret said, go to where people are, right? So folks they trust their church, and what we're trying to do is to get to the church, and we do these during the week, but we also have most recently with the flu vaccine, we literally went to several churches in central Brooklyn on a Sunday, and we had engaged with the minister to include in his or her sermon the importance of getting an immunization, and then we provided those immunizations. So that's sort of that level. In terms of contractual relationships, we don't, where the money's flowing, we haven't gotten there yet. I think the biggest deal will be with our being able to provide some capital dollars. It was mentioned, earlier that, health and human services organizations don't have a tranche of capital dollars. The one thing that I'm also envisioning, for example, is with these capital dollars, we'll be able to expand space in ambulatory care centers that are operated by One Brooklyn, and we want to create space for human services organizations and CBOs, because we are very sensitive to the fact that the rent in Brooklyn is basically creating additional stressors to our human services and CBO partners. Folks are pressured with, their limited budgets and what they're being asked to pay for in terms of rent. So we want to be able to create that space and frankly enable CBOs with whom we have a working relationship to be in our locations. So again, that's a future plan. We don't have that yet, but that's what I would envision our being able to do. And I would say another, I was just talking to Bob there from Community Health Network, another thing that we envision, again, is being able to create the opportunity for co-location. So that the patients that we're serving can get the services they need beyond that, 30-minute clinical visit, but that it be physically located and easy for access.
So it sounds like many of these relationships that you've established are based on your relationship with the community, and it doesn't sound like that you necessarily need the state to intervene to create more of these relationships.
Well, yes, I do. So, I've had a lot of people in my 2 years at Interfaith come and meet with me and say, if we could only collaborate. And sometimes what that means is, if you could only fund us to do things. Well, I'm saying to, on any given week, I might have 2 weeks of cash on hand. Our hospital can't afford to resource that relationship, which I know is incredibly important. The folks sitting in front of me have no money, and I have no money. So you got two poor folks, but we have a will, and we have so from my perspective, perhaps there needs to be this fund in what that could even seed, SEED, not CEDE, but seed that relationship, because I can appreciate having come from a very large system where there are, even though it was a public hospital system, it had a lot more resources than when I walked into the small safety net hospital and I looked around and there was one person doing managed care contracting and not so good. Or there was one person doing this when I'm used to hundreds of people doing things. So I think there is the necessity to recognize that collaborations cost, and you can't do it on the cheap, and people just can't do it for free. Even when there is a deep and abiding commitment to do it, sometimes you need the resources to facilitate it.
Margaret, do you want to comment on that?
I don't even think it needs comment, but I feel like I've found my soulmate. Yes, I mean, and so many of the things we do are relationships with you guys, relationships we have that we, sort of say, oh, by the way, let's meet at 5:00 on Friday and figure out how we can, provide extra services. Some of it is with a transaction, some of it is without a transaction. But the idea that collaborations, just that there's somebody waiting in my office for the next collaboration idea to come, and that somebody takes the calls, is crazy. I do think the question of why we need the state is to scale it. And I'll go back to my community school example. Each community school is a CSD, a community school director. Mm-hmm. Their role is to go out and personally find, like walk the streets and find neighborhood collaborations, leverage the community resources. And principals will say, thank God, because nobody else is doing that for our families. Mm-hmm. And so again, it's on a very small scale, but we've got 17 of those in East New York. So how do we think about it's again about scale and not just about personal relationships, because some of those will go away if certain members of our staff go away.
Our next topic, I think, is pretty straightforward, although very difficult to implement. And so the report, one of the recommendations is the development of standardized contract language for contracts between payers and human services CBOs. Margaret, would this type of language be helpful, and what types of things should it include?
Yeah, I mean, if you just think about the cultures of big hospital systems and medium hospital systems and CBOs, and we all actually need to change our language to be not only less clinical but more patient-centric and more trauma-informed. So I think there's an opportunity to do that as we're all sort of evolving together. But certainly things like patient versus client, all those things are, social determinants of health. Every single word associated with social determinants of health is a live nerve because we're using different language. The DOE is using different language from the DOHMH. I'm using different language than our colleagues at Counseling in Schools, even though we're doing exactly the same work. So in order to have transparency about deliverables, we just need to greatly simplify. We need to know what we're responsible for, and it needs to be transparent that everybody in a collaboration knows what their roles are.
So, Denard, this seems like a good role for the state. Would the state consider sanctioning standardized language for contracts?
Well, actually, I think that I know that one of the challenges that we had when we began to talk about VBP contracts and people entering into VBP contracts is that when you're working with a value-based payment contractor or a MCO, there are multiple types of contracts that you can enter into. So there are provider contracts, there are administrative contracts, and we were struggling with the concept of, okay, well, what type of contracts are these community-based organizations actually entering into, because we were hearing back from many of the CBOs that they weren't comfortable entering into a provider contract. It was more involved than they were used to, and they weren't comfortable. So we began to look at that and say, okay, well, maybe what we should do is we can allow for the administrative contracts and with a negotiated bonus, possibly, as was mentioned in the report. And so with these administrative contracts, there are models out there in the state where there's standard contract language. I think we use them with the health homes, where there's standardized language. And so we are open to the concept. If it's needed, I think that at this point in time, we're currently not developing it, but I think we're open to the concept of developing standardized language if that's what's needed.
Great. I'm sure Allison will follow up with you. The next topic is measurement, which of course has plagued the healthcare world for decades, and now we have over 600 healthcare measures in common use, and we're moving into measuring social determinants of health interventions, which remains an even bigger challenge for a variety of reasons, including that many interventions take time to produce results. So, Lorraine, what ways have you grappled with measurements as it relates to social determinants of health? What type of measurable deliverables do you think CBOs can offer, and how might you involve the CBOs in a process for deciding what to measure and how much it's worth? That's a lot in one question.
That's a lot of questions. From a healthcare provider's perspective, we would be looking to the human services or the CBO to guide us. We're struggling with those 600 plus measures. But what I would say is that, with value-based payment, and let me even back up for that. So from that, some hospitals, some safety net hospitals get some subsidy from the state, which for several years that subsidy was provided for, as someone had said here, just pay for reporting. Then the state decided that no, we couldn't do that, and it's been made overly complicated, I believe, but that a certain amount of this subsidy, and I understand that the negotiations with the feds were it should be part of value-based contracting and there should be outcomes, but those of us who are getting that subsidy, we're doing that to keep our doors open and to make payroll, but we understand. So now some of that subsidy is driven by performing on certain quality outcomes. One of the quality outcomes that my system chose had to do with emergency room throughput, emergency room use. To me, a perfect level of support around emergency room use is working with community-based organizations, human services organizations, behavioral health organizations to help us achieve the outcome that we need. But our measures are readmission rates, and not necessarily, well-being of that person that they're in the community, or not necessarily, some measure of how has their social support network been strengthened, which I know, having worked in behavioral health a few decades ago, understand that those things are as critical a measure as to success for an individual's community tenure. So what I would say is we're struggling because we have to meet certain performance measures, and we have to provide certain clinical data to our payers, including the state, which is our biggest payer, but to managed care companies. But we also know that the information that's most meaningful isn't that information. So frankly, I'm open to folks helping us in those negotiations around, which will become more and more important as we move forward on that roadmap, put forward together meaningful criteria of or measures of success in terms of performance.
No, that's great. So what I'm hearing is that we need to broaden the conversation. This isn't only about measurement from the CBO perspective, but we need to rethink as entire health and human services combined sector, what does value mean?
Right.
And
maybe
value
just
doesn't mean just avoiding hospitalizations,
right.
But health and well-being as well. Well put. And we're going to have a little time for audience questions, so people should start preparing them. But a last question for Margaret. Is your organization prepared to enter into a relationship with a healthcare provider today? And what would you need, and what would you say that you offer?
So probably the candid answer is no, not really, although we're pitching it all the time because because we feel like there's just a missed opportunity. I love the idea of a big hospital system saying to us, like, what do you think we should measure?
Maybe it's because we're not so big that I'm going to say that.
Just as one of my favorite stories is, I guess, when the typhus epidemic broke out, the big prescription was democracy. Democracy will solve the spread of epidemics. So just in terms of what we should be measuring. So I think what we offer is, we have been paid by non-performance-based contracts to develop trust and credibility in the community. And now we offer that. We know families, we know where they live, we know when they've lost their housing, we know when they've moved in with somebody else, we know when the mom has an issue that the child is late for school, we know when children have, a younger brother or sister that has an issue. We know when the mom is pregnant. We know all that stuff, and that's because people trust us. We are credible messengers in most cases. We also have built, as has been said, our own data system because we did it along the edges and with, figuring out how to get private money to do it. So we have a pretty robust set of data our data system can't talk to anybody else's, but we have a lot of information about social determinants of health in our own words. So we can tell you all sorts of demographic information to the point where, ACEs can really predict, the number of adverse child experiences can predict not only your mental health, but your physical health for years to come. So we could pretty much tell you this kid has, 3, 4, 5, and not only are they 36 times more likely to have behavioral issues in school, they're 8 times more likely to have chronic health problems, diabetes, emphysema, all the things that are expensive for the healthcare system. We can predict that. I think one of the challenges we have is aligning catchment areas. Our catchment area is our school, but if we have 17 to 25 schools within walking distance, there's got to be something we can be talking about. I think we also can do follow-up. So not that we're doing home-based care, but we can keep track of kids, and kids and families are totally intertwined. So we have so much information about families. So I think basically, one more thing we do is we have trained ourselves to be really good at trauma-informed care. So we're training school-based personnel in trauma-informed care. That's actually really important with dealing with the communities. But in terms of our preparedness, there's nobody on my staff who I could say, okay, Lorraine's got somebody who, we're in your area.
I know you are.
All over. And here, just talk to this person, and we'll figure this out. So we don't really have that role. Our clinical social workers who go into schools don't have extra time to track 17 more things, or even one more thing. So we would really have to think about our own organizational setup, just like the seismic shift to VBP is asking everybody to do. Right. So are we prepared in terms of will? Absolutely. In fact, we don't actually see many other ways forward, but we would need to have some of the capital investment. We'd actually even have to have those conversations, because we'd have to think through what are the things we want to measure, what are the outcomes we think we can offer, and we need to do that in conversation. Right.
Well, I wouldn't feel bad about not doing it right now, because I think back into healthcare, and it took us literally decades to figure out how to coordinate between primary care and specialty care. And we still screw that up. And forget about coordinating between hospital and nursing home or long-term care, and that's all within healthcare. So to believe that we're going to figure out how to coordinate between healthcare and a completely different sector in a matter of 1 or 2 years is fantasy. We're playing a long game, and again, to achieve our shared goals of improving health and well-being for our communities. Any audience questions? Elizabeth?
Hi, I'm Elizabeth Benjamin from the Service Society, and this report is fantastic. Thank you for putting it out. I wondered, as we've been really fortunate to partner with Health and Hospitals, one city, not one Brooklyn, although we'd love to, with one city, New York, to work with community-based organizations. We've been working, we're asked to work with a tool that had been developed out in California by a group called Collaborative Consulting that sort of walks, it works, what they did is they were paid by a group of funders to work with community-based organizations to help them walk through a series of 6 domains about how to develop their own capacities to be able to start engaging in value-based contracting with the healthcare sector. And so what we were asked to do was because we work with CBOs for decades now, in developing networks of community-based organizations, was to go out and work with, whoever the one city partners that held their hands up, and there were 52 organizations that held their hands up to go through this essentially 10-hour process, 3 or 4 hours with their own leadership team, and then 3 or 4 hours with our team to kind of work through these 6 domains. And I was wondering if, as you guys went through your processes, if you thought, and I haven't had a chance to read the report, but it seems like it, do you think it would be helpful for community-based organizations to go through these sort of self-assessments to work through, these domains around where are they in adaptability? Do they have someone dedicated to, answer the phone with a managed care plan, sort of, go do marketing, working through the technology? Because we found we were shocked. We did like a sequence Survey Monkey, and they could anonymously report on the process, and they, like, I had never gotten a 90 on anything, basically, I mean, from all my education, I never gotten a 90, but people really seemed to respond to this, and we were like, this can work for them, you know? And it was a really incredible process, and we'll be issuing a report about this, but I was curious if you all or your commission had talked about that kind of work, and, you know, if you've heard about this California, I guess they're also.
Yeah, so the California, that was raised, I think I've heard it in different areas too. So the answer is yes. I think that that's further work that should be done, right? And that's the idea of what we're sort of outlined, the areas that need to have further conversation. And I think we'd really be interested in looking across the country at examples of where people have looked at this and what they learned from it, because I'm sure it wasn't perfect and there were things that we shouldn't repeat that were mistakes made, as well as things that really, went well and resulted in positive things. So absolutely, I think that that's exactly the type of continuation of this blueprint that we'd like to do. So I'd love to talk to you more about that process, and I'm interested in seeing the report that you have and to figure out how do we advance those conversations further. So absolutely.
We're going to go to Rachel and then back here and then Louise.
Well, we just connect what Elizabeth said with some things that came up earlier. And so Elizabeth was talking about going through a step process that sort of systematizes what you were getting at, Margaret. You don't have a staff person to do that. You don't have a system that's interfix. You don't have, et cetera. That agenda will result in a long list of things that need to be done and and so disconnect, of course, is the 80% on the dollar in the human services sector. It brings me back to a comment that Tony Chi made in one of the commission meetings, where he basically said, there's going to be a lot of money needed in order to bring the social service sector, even a subset of them that have most to deliver, up to the level, because they can subsist on 80% on the dollar. And so there just is no dollar, there are no dollars to invest in, as Lorraine said, some safety net hospitals is. So there's a disconnect between understanding the issues, understanding the culture divides that the learning collaboratives have pointed at. There's many things we can do, but at the end of the line, if there are dollars to bring at least a subset of the sector up to the level needed in order to really play ball.
Yeah,
So I'm going to be a downer because that's the reality, but we have to figure out strategies that at least implement and address that.
Yeah.
Thank you. Nancy.
Hi, I'm Nancy T. Miller. I'm the CEO of Vision Services Supply. And I was part of the commission. It was an amazing process. And in the report, we use the term accessibility, and accessibility means different things in different communities. Language, physical barriers. As we talk about building the CPO system, and I look particularly at the state, are you taking into account the accessibility to people who are blind? 33% of my staff are blind. If you build a system that blind people can't access, that disenfranchises them both as patients, but also as potential workforce. So I just wanted your thinking at this point in doing these community meetings, of making sure that all the voices, I'm the tier one, I just know that. I'm learning the way to collaborate, but are you making sure, and I did fill out your survey, are you making sure that voices that don't necessarily always get heard are included in these community meetings? And how are you making sure that those of us who may not be a part of the process yet are part of the process now?
Very good question. I think that what we're doing is we're trying to be as inclusive as possible, and what we're using in order to put together our invite list. We're actually using some of the networks that are already out there. Like we're using the PPSs, and they actually have networks and people that they actually touch, and we're using the FIPS and they have networks of people networks of organizations that they touch. And so we're trying to be as inclusive as possible. If someone is overlooked, or if there's a community that you feel is not being served, by all means send the information to us, and we'll make sure that we get a hold of them. As you all know, in this room I'm speaking to the choir, there's when you say the human service CBO community, it's vast. And I would be nice if it was like 100 of you guys. You say, hey, we're all 100 in the room, but it's vast across the state. And so, I can't say that we're going to get it perfect, but we're going to try really hard to get it right.
Louise, last question, and then we're going to need to wrap up.
I think one of the conundrums of this process is that the state health and other government agencies pay for the services at the human services level on the one hand, and pay for Medicaid for services on the other hand, and these systems are talk to each other. So now what we're trying to do is we're actually trying to fix the system from the bottom up, when there's actually a problem from the top down. And I think, imagine, if you will, an organization who provides counseling for students in schools, who has an attributed population, is essentially capitated, albeit at a 10% less than it actually costs to do it, but let's just imagine. That sounds a lot to me like value-based payments. And so what I'm confused about is value-based payments, the definitions that we've created at this point for the Medicaid system has a lot more to do with cost savings, how you manage to go to cost saving, than it does about some of these other things. And I think that if we actually look at the reality of how human services organizations are funded, they are not funded on this fee-for-service basis. It's not widgets, it's for a community, for capitated services. I think we boxed ourselves in here. I guess I would like to hear, what people's thoughts are about these are in fact value-based arrangements. They may not yield, or they may not be counted for shared service, shared savings as a contract. They certainly require outcomes. They certainly require process things. They're care management plans and all kinds of things. And they're measuring how those students are doing. So I feel like we're already in this system, but it's actually the way that we fund these two systems actually comes from the way that state and local government actually pays for those systems. So I would like to hear a little bit more about why we're thinking so much that we want to transform the social services systems to be able to fit into the Medicaid bucket that are already being paid for by the state through different mechanisms that seems to be much more aligned with what we're talking about.
Well, one of the reasons that we're worried about it is that at some point our contracts end, right? And they're completely tied up with different administrations. And so so in our heads, we have healthcare funding as a more sustainable stream. And now that's questionable too. But the other thing is we're using proxies. So we're using social emotional learning as proxies for general health. And so, you're right, we could, but it's a community, and there are certain things that we can't, an attributed community that we also can't provide. And once we're outside of what we can actually do, we don't have good ways of doing that. But the very simple answer is our contracts end.
We are coming close to the end of the hour, so Allison, do you want to make any closing remarks?
Yeah, sure. So I just want to, again, thank everybody for spending the time to think about this. Clearly, I don't expect ever to have a panel discussion and be like, okay, we wrap that topic up, home and start doing that, integration. So I think there's always more questions than answers, but I think debate, I'll tell you, when we started this process, we weren't as clear as we are now about what the issues really are and what we need to tackle. And so I feel like we've come a long way, and we have a long way to still go. But I think these are all the right questions. It's great to know that we have a partner in the state, in the healthcare side, and in human services. This is really our attempt to say, we want to be helpful here. We want to make this integration happen. And these are the things that we really need for that to take place effectively. And ultimately, this is all about serving communities better, and that is what's driving all of us together. So,
great. One last round of applause for the panelists and Allison. Thank you.